Sampling and data collection. The main methodological issue that influences the generalizability of clinical research findings is the sampling method. In this concept brief, I'm explaining the different sampling methods in clinical research. In clinical research, we define the population as a group of people who share a common character or a condition, usually the disease. If we are conducting a study on patients with ischemic stroke, it would be difficult to include the whole population of ischemic stroke all over the world. It is difficult to locate the whole population everywhere and to have access to all of the population. Therefore, the practical approach in clinical research is to include a part of this population, called sample population. The whole population is sometimes also called target population, while the sample population is called the study population. When doing a research study, we should consider the sample to be representative to the target population as much as possible, with the least possible error and without substitution or incompleteness. The process of selecting a sample population from the target population is called the sampling method. Inclusion and exclusion criteria define who can be included or excluded from the study sample. The inclusion criteria identify the study population in a consistent, reliable, uniform, and objective manner. The exclusion criteria include factors or characteristics that make the recruited population ineligible for the study. The investigator must specify inclusion and exclusion criteria for participation in a study. Inclusion criteria are characteristics that the prospective subjects must have if they are to be included in the study. Exclusion criteria are those characteristics that disqualify prospective subjects from inclusion in the study. Inclusion and exclusion criteria may include factors such as age, gender, race, ethnicity, type and stage of disease, the subject's previous treatment history, and the presence or absence, as in the case of healthy or control subject, of other medical, psychosocial, or emotional conditions. Healthy or control subjects may be defined as those individuals who are free of certain specified attributes of non-health. Defining inclusion and exclusion criteria increases the likelihood of producing reliable and reproducible results, minimizes the likelihood of harm to the subjects, and guards against exploitation of vulnerable persons. An example of inclusion criteria for a study of chemotherapy of breast cancer subjects might be postmenopausal women between the ages of 45 and 75 who have been diagnosed with stage 2 breast cancer. An exclusion criteria for this study might be abnormal renal function tests if the combination of study drugs includes one or more that is nephrotoxic. In this case, it would be required to specify which tests of renal function are to be performed to evaluate renal function and the threshold values that would disqualify the prospective subject. Furthermore, the investigator must be prepared to provide a rationale in case one or more of the inclusion or exclusion criteria is questioned. The investigator should review the inclusion and exclusion criteria and decide if any groups are inappropriately excluded. If the justification for the exclusion of this group is not reasonable with regard to the risks, benefits, and purpose of the research, then this group should be included. In the breast cancer study example discussed earlier, there would be no justification for the exclusion of minority women, but there is justification for the exclusion of men, based on the target population of the research. A representative sample is a subset of a population that seeks to accurately reflect the characteristics of the larger group. For example, a classroom of 30 students with 15 males and 15 females could generate a representative sample that might include 6 students, 3 males, and 3 females. If you are conducting research on a specific population, you will want to make sure that your sample of that population is representative. If your sample is representative of your population, you will be able to confidently generalize the results of your study to that population. A representative sample is one that accurately represents, reflects, or is like your population. A representative sample should be an unbiased reflection of what the population is like. There are many ways to evaluate representativeness: gender, age, socioeconomic status, profession, education, chronic illness, even personality or pet ownership. It all depends on how detailed you want to get, the scope of your study, and what information about your population is available. Lack of representativeness also comes from sampling errors or biases. An example of sampling error would be conducting a survey of how many people eat dairy products by recruiting participants from your local popular vegan cafe. Another example would be studying the drinking habits of college students, but only sampling from members of fraternities. In these examples, it's easy to see how the characteristics of the samples may potentially bias the results. Sample selection is a key factor in research design and can determine whether research questions will be answered before the study has even begun. Good sample selection and appropriate sample size strengthen a study, protecting valuable time, money, and resources. In the context of healthcare research, poor design could lead to use of harmful practices, delays in new treatment, and lost opportunities for high-quality care. Not every study can achieve design perfection, and researchers often seek a balance between the ideal sample and one that is feasible or convenient, acknowledging the limitations of their design decisions. Too small a sample will yield scant information, but ethics, economics, time, and other constraints require that a sample size not be too large. Well, how many subjects do I need? Neither 7, nor 30, nor any number is an all-purpose answer. A sample size of 30 is a large sample in some textbook discussions of normal approximation, yet 30,000 observations still may be too few to assess a rare but serious teratogenic effect. The best first response to how many may be not a number, but a sequence of further questions. A study's size and structure should depend on the research context, including the researcher's objectives and proposed analyses. So if a survey is to be carried out for descriptive purposes, such as assessing the prevalence of some characteristic, the sample size is based on the required precision of the prevalence estimate. For example, why are so many national opinion polls based on samples of approximately 100 or 1,000 responses? And if the poll results are valid on a national level, how valid are they on a state level? Often researchers will begin a study by asking what sample size is necessary to produce a desirable power. This process is known as power analysis. It shows nicely how sample size and power are interrelated. A larger sample size gives more power. While the particulars of calculating sample size and power are best left to the experts, even the most mathematically challenged of us can benefit from understanding a little bit about study design. Next time you read a research report, take a look at the methodology. You never know. It just might change the way you read results. Now, data collection. Nurse researchers have a mecca of various data already at our fingertips, including hospital records, school records, corporate records, letters, meeting minutes, photographs. These are records from which we can pull data for analysis. We can even request that this data is de-identified to protect privacy. In this way, we can sort through thousands of data. Other types of data collection methods include self-reports, patient-reported outcomes, observations, and biophysiological measures. Let's talk about some of these. Structured self-reports are collected with a formal instrument. This instrument can be an oral interview, where pre-specified questions are asked orally via face-to-face interviews or even by telephone. And then questionnaires. These are one of the most common ways to gather data for nurse researchers. These pre-specified questions are in written form and can be emailed, mailed, or even handed out in various settings like conferences or schools. Now, the types of questions in an interview or a questionnaire can either be open-ended or closed-ended. With open-ended questions, these prompt the respondent to divulge more information. Basically, it helps to open dialogue. However, if we are interested in very basic information, such as yes or no responses, we can use closed-ended questions. The advantages of questionnaires in comparison to interviews is that they are usually less costly and can be sent to huge dispersed samples. They also offer anonymity if we want. The advantages of interviews in comparisons to questionnaires is that sometimes we can get higher response rates because we are present in collecting data. With questionnaires, yes, we can send them out or hand them out, but the response rate might be low. People might just toss them into the trash. The other advantage of interviews is that it gives the data collector some opportunities to clarify questions, determine comprehension, and also collect observational data. And let's talk about some other methods to collect data. Composite psychosocial scales are methods to assign a value or number to a continuum. These are completed by the research participant, and the data can vary depending on the participant. There are a few different types of scales, but the most common you'll see are Likert scales and visual analog scales. A Likert scale is a line that has various statements across the line, and these statements usually vary from agree to disagree. For example, you may have taken a Myers-Briggs personality type assessment before, and that would be an example of a Likert scale. Basically, it gives you options such as somewhat agree or completely disagree, and so on. This varies from a visual analog scale in which there are just two choices, both on opposite ends of the line. It is up to the participant to mark their choice somewhere along the line, but without particular declarative statements within that line. Self-reports are somewhat self-explanatory, but they are basically a method to gather information from a subject on a broader sense. Observation is a method in which a participant is observed doing something. The researcher or data collector observes pre-specified behaviors that they are measuring in those observed. The researcher is usually concealed so that the participant does not change their behavior due to the knowledge of being observed. The researcher will usually have a predetermined method of recording observations. For example, perhaps they want to know how many times the participant scratches their head within a 1-hour time period. The researcher will simply write down the numerical finding. Or perhaps they want to observe body language of someone in an uncomfortable confrontation. They may be collecting data on how they cock their head, hold their hands to their waists, or pace back and forth in a room. And in another example, perhaps we are measuring a pain response via facial expressions. Observation is excellent for capturing many clinical phenomena and behaviors. The major issue is the risk of biases on the part of the researcher, however. This can be minimized with careful observer training and assessment. And then finally, biophysical measures. These can be in vivo measurements, which are measurements performed directly within or on living organisms. An example could be blood pressure measurements or an ultrasound for a DVT. In vitro measurements are measurements done on something outside the body, such as urinalysis, blood glucose measurements, or blood cultures. And that concludes our concept brief on sampling and data collection.